The following podcast is part of a certified educational activity titled Making the Most of Treatment Advances in SCLC, New Standards, Practicalities of Care, and Hope on the Horizon, featuring Dr. Jacob Sands from Dana-Farber Cancer Institute and Harvard Medical School in Boston, Massachusetts, Dr. Tiziana A. Leal from University of Wisconsin Carbone Cancer Center in Madison, Wisconsin, and Dr. Jared Weiss from UNC Lineberger Comprehensive Cancer Center in Chapel Hill, North Carolina. Access the entire activity and complete the post-test at peerview.com/FJX860. Downloadable slides and practice aids are also available.
Welcome everybody to a discussion on small cell lung cancer, making the most of treatment advances. There is a lot going on and a lot to discuss. I am excited to be joined by two exceptional colleagues in this discussion today, Dr. Leal from the University of Wisconsin and Dr. Weiss from UNC. Okay, so we're going to be discussing navigating the current and emerging options in the small cell lung cancer treatment arsenal, state of the science, and practical considerations. But let's start with a little bit of background. So diagnosis of small cell lung cancer, standard immunohistochemical markers often show TTF1 and neuroendocrine differentiation. So synaptophysin, chromogranin, CD56 are common markers. Small cell lung cancer has a high mitotic rate. It is a transcriptionally active cancer, and common genomic markers include p53 mutation, loss of RB1, MYC amplification is also seen in small cell lung cancer. Now, for some historical context, up until recently, the treatment options have really been drugs that have been around for many years. Cisplatin and etoposide was introduced in the 1970s. Carboplatin is now a commonly used drug as well, kind of a sister drug to cisplatin. In general, I'd say some of the biggest advances in cancer treatment really up until, well, about 10 years ago, some of the biggest advances at that point were really drugs to help people tolerate the chemotherapy better. So antiemetics have made a significant impact on patients' quality of life. And this is especially true for something like cisplatin that previously caused a lot of nausea and vomiting that nowadays is much better tolerated. Small cell lung cancer in the first line setting is often very responsive to chemotherapy. But that being said, survival has been limited by the fact that at the time of progression, it's often very resistant disease. And so these are the kind of curves where we see a rapid drop off that one of my attendings in fellowship used to say that these curves are not skiable, which is to say there's a steep drop off and represents very poor prognosis. Now, responses are transient with chemotherapy. Patients often have very nice and very rapid and can be very significant responses to therapy that really improve and reverse any symptoms that were causing the disease. But at the time of progression with resistant disease, survival is limited. So historically, median progression-free survival of 4.3 months and an overall survival of 8.6 months. Now, there have been some real challenges in advances in small cell lung cancer, and until recently, we really hadn't seen many. We're going to discuss some really exciting recent advances in small cell lung cancer treatments, as well as ongoing and future directions that are promising. But in this patient population, these are patients that often have a very extensive smoking history, and that often comes with comorbidities that can be challenges. On top of this, the disease often progresses very rapidly, and this has presented a real challenge for clinical trial development because patients need to immediately go on a next line of therapy, and sometimes the time that it would take to then enroll and prepare for a trial or some of the other things that go along with trials, such as biopsies and other interventions prior to the treatment, these delays, even if it's just a week, can preclude some patients from participation. And so this has been a challenging clinical scenario. At the same time, it's a disease that has a lot of genomic alterations. There's a number of mutations, but hasn't been something that classically was as responsive with immunotherapies such as melanoma. But we'll get into some of that as we go on, some of the details of that. Now, when looking at the NCCN guidelines, as I mentioned, we see platinum etoposide. This has really been the mainstay of treatment for years at this point. And we see an introduction now of immunotherapy in the first line setting, which represents really there hadn't been advances for years, and now we see new drugs in that setting, which is exciting. And in the second line and beyond, we do have some new introductions, but not an array of them. And so we'll focus on a few different treatments that are really new, as well as some of the drugs that have been on this list for years at this point. As an initiation, let's mention a case, and we can consider this as we begin a discussion about some of the data for small cell lung cancer. So, a 72-year-old man presented to the emergency room for worsening shortness of breath over the course of about a month. Now has difficulty walking across the room due to the shortness of breath and having difficulty catching his breath. Used to do yard work, was active until very recently when these symptoms really became too much. Has about a 60-pack year smoking history. CT scan showed right lung mass and bulky mediastinal adenopathy. Liver metastases noted. MRI brain shows 2 brain mets. Biopsy of the liver was done and does confirm small cell lung cancer. So kind of a classic scenario of somebody presenting to the emergency room with a new diagnosis. Now, before we get into the first line treatment, Dr. Weiss will discuss trilaciclib.
So I want to start by asking you to think to yourself, what are the major side effects of small cell lung cancer chemotherapy? Certainly prior to getting involved in the work that I'm going to share with you, I might have said nausea, I might have said alopecia. If we're going to mention blood counts at all, I might have mentioned febrile neutropenia. Let's take a moment and reflect on what the numbers actually show. So we're looking here at data, toxicity data from Empower 133. This was a randomized study of carboplatin etoposide alone or with the addition of the PD-L1 inhibitor atezolizumab. We'll talk more about the efficacy data later. I would note parenthetically that the themes are the same with durvalumab. What I've highlighted for you in red here are that the major toxicities are actually hematologic, whether you look at all grades or grade 3-4, and this is no different in comparing the placebo group or with the addition of PD-L1 inhibition. And in fact, I would challenge you to look at the white space, or what is that, a beige grayish space remaining outside of those red outlined boxes, and you'll see that you're not representing terribly high numbers compared to what is in the red box. And so I'm asking you to think about things a little bit differently. Philosophically, in the arbitrary sense, we talk, in the philosophical sense, I think we would all endorse that we treat extensive stage or stage 4 small cell with 2 major goals in mind: helping our patients to live longer, which we'll talk about through most of the program, and improving their quality of life. But I think once we put our white coats on, sometimes I think we forget that of the drivers of that quality of life. Some of them are none of our business, of course, but in terms of physical quality of life that we can have impact on as oncologists, the 2 dominant factors are suffering from the disease, and we'll talk a lot about disease control with our new agents today, but the other is the toxicity of therapy. And I've shown you in the red boxes here, myelosuppression or blood count suppression are major drivers of that toxicity. Of course, for 50 years of platinum etoposide, we haven't had much to do about it, so there was really not a lot of cause of sitting and ruminating on it, but now we do, and so I think we need to revive that basic philosophic conversation. So let's start by talking about what trilaciclib actually is. Trilaciclib is an IV CDK4/6 inhibitor. You may have heard some about these agents in the context of breast cancer and other cancers. Well, small cell lung cancer is obligate RB null, which in plainer English means that you wouldn't expect CDK4/6 inhibition to have any effect on the tumor cells. for better or for worse. And so small cell was a good place to start to purely and safely study this agent. The basic idea is that it's going to hold the bone marrow progenitors out of cycle while the chemotherapy is washing by, with the idea of not only preserving blood counts, but preserving those myeloid precursors in the marrow. This idea was studied in 3 randomized phase 2 studies in small cell lung cancer. The first looked at newly diagnosed patients treated with carboplatin and etoposide with or without trilaciclib. Of course, while we were conducting that trial, the standard of care happily shifted under our feet for the addition of PD-L1 inhibitory therapy. And so a study was conducted of carbo-atopo-atezo plus or minus trilaciclib. And finally, while I don't think there's a lot of residual love for topotecan, that study shows what trilaciclib can do in the context of an already beaten up bone marrow. Let's start with the data on carbo-atopo-atezo because that's probably the most impactful to your clinical practice. The primary endpoint of this randomized phase 2 study was duration of grade 4 neutropenia in cycle 1 and proportion of patients with grade 4 or severe neutropenia. And what you can see in the red box is that median duration of grade 4 severe neutropenia was reduced from 4 days to 0 with the addition of trilaciclib to carboplatin, etoposide, and atezolizumab. And the proportion of patients with grade 4 severe neutropenia was reduced from 49% to 2%. In considering the transition from this data to the box below, I want to point out an important element of trial design for each of the 3 trials. In order to show the difference for trial purposes, supportive care agents like ESAs and critically here Neulasta were not allowed in cycle 1, but were allowed in subsequent cycles. And so what that meant was that the trilaciclib was attempting to prevent the need for those agents, but if they were still necessary, they could be layered on, that these can be safely used together. And so what you see as a consequence is that as you move from the numbers to their consequences, patients with febrile neutropenia as an adverse event had a trend and decreased from 6% to 2%. And patients with G administration, as you would expect, was reduced from 47 to 30%. Again, a trend, not significant. And so what that's showing is that in a large proportion of patients, you can avoid the use of those supportive care agents because some of them, like Neulasta, have their own side effects, in particular pain. But for the proportion of patients that still needed them added on, you could add it on in addition to what Trilla had already given you and further decrease these events. Similar themes emerge, or trends, I should say, as we look at other lineages. Patients with grade 3/4 anemia had a trend towards decrease from 28 to 19%. As you would expect then, fewer red blood cell transfusions from 21% to 13%. And I don't know who's still using ESAs, but apparently people are, from 11% to 6%. Thrombocytopenia isn't a huge problem in our practices because the body comes with a lot more platelets than you need, but they can lead to dose delays that are inconvenient for patients. Grade 3/4 thrombocytopenia was significantly decreased from 38 to 2%, as well a trend towards decreased platelet transfusion. No significance whatsoever there, P of 0.6, as you might expect given the rarity of the events. Now, of course, as I mentioned, there were 3 randomized trials. The data are rather similar between each of them. And so instead of taking up all your time going over them, I'm just going to show you further the pooled data that it shows rather similar themes. And of course, here, with the greater power that comes from relatively homogeneous and similar data, we achieve more significances. So grade 4 neutropenia, same effect. Febrile neutropenia, the trend remains. G administration, the theme remains and becomes significant. And you can see so on down the line that we start to achieve more statistical significances with the pooled and relatively homogeneous data between the trials, and that the themes of the magnitude of protection remain. Now, I've shown you a progression from mechanism of action to numeric count preservation to reduction in adverse events one of my own first critical questions as I started to digest this data some time ago was, well, what did this actually do to quality of life? Again, one of the primary purposes of treating cancer, and if this is supposed to be a quality of life drug, that's something we need to see. Now, I've shown you a numeric reduction in myelosuppression, and that resulted in reduced adverse events. A key question, and my first critical question as I first digested this data was, did we improve quality of life, right? One of the two major, if not the most important philosophical reasons that we treat cancer, and the main goal of this drug. It was intended to be a quality of life drug. As you can see on this slide, physical well-being was improved. Functional well-being was improved. That third measure, fatigue, is the one that I care the most about and was looking forward to seeing the most. If we're preventing anemia, as the numbers as well as the next two indexes showed, what we'd hope to help with is fatigue. Fatigue is one of the most common complaints vis-a-vis quality of life from our patients. Prior data shows that, as you might expect, fatigue and quality of life, fatigue goes up, quality of life goes down as patients become more anemic. And happily, there was a significant, and I believe rather meaningful effect. And this is really important to me as a clinician, because this is one of the quality of life impacts on patients that I feel least equipped with our current armamentarium to do much about. Now, normally when we layer on an additional drug to an existing regimen, like carbo, atopo, atezo, the question is, well, how much did we harm toxicity profile in exchange for whatever treatment-related advantage the drug provides us? With trilaciclib, you really need to flip that question on its head a little bit. It's a quality of life drug. It reduced the total toxicity of treatment, as you would hope that it did. And really, we need to flip the question on the head and say, was there any cost in terms of disease-related outcomes, such as PFS or OS? It didn't in the individual trials. And here I show you the pooled data showing that same effect. Absolutely no impact, for better or for worse, on PFS or OS, just as you would expect. And I say just as you would expect because historic data teaches us that, unlike, for example, breast cancer, treatment intensity doesn't seem to help with outcomes in small cell. It's been tried repeatedly. I won't bore you with the historic efforts, but it never worked, increasing the intensity of small cell therapy. And because, as I mentioned earlier, small cell is obligate RB null, you wouldn't expect any direct effect, for better or for worse, on the tumor cells. So what were the adverse events? I've picked out 4 adverse events of special interest to show the warts that do exist, as well as one improvement that's rarely talked about, but I think does matter. Injection site reactions. We certainly saw this in the trial. There were 17% at low grade, no grade 3, 4 injection site reactions. These could be helped by reducing the speed of the infusion or rotating sites in patients with central lines using them. Same goes for the next 2 adverse events, phlebitis, which happened in 8% of patients. In addition, cold packs can help in addition to slowing the infusion and rotating sites. Acute hypersensitivity occurred in 6% of patients, but none at high grade. Thromboembolism was a common adverse event. Low grade reactions, 3%. But I would note that there were 2% all grade events in the control arm and 1% high grade there. So it's not clearly different between the arms. And then one adverse event that isn't that much spoken about here, but I find kind of interesting and perhaps not unexpected, is that the rate of alopecia was nearly halved from 25% with standard of care to 13% with trilaciclib. And so to summarize the trilaciclib data, in my opinion, there's a clean progression from mechanism of action to numeric count preservation, to reduction numerically in adverse events, to improved quality of life. There was no harm to PFS or OS. There was a reduction in high-grade 3-4 events and improved quality of life, especially fatigue. And I summarized for you in pooled analysis the high-grade events for your reference, the magnitude of the reduction. And with that, it's a pleasure to pass the virtual microphone over to my colleague, Dr. Leal, to talk about first-line therapy.
Thank you very much, Dr. Weiss. I'll take over to talk about chemoimmunotherapy as the new standard of care. We know from prior studies that small cell lung cancer is one of the tumors that has the highest tumor mutational burden, so it made a lot of sense to investigate immunotherapy in this disease. And one of the first efforts that we've seen now for years is the addition of nivolumab plus minus ipilimumab for patients in the previously treated setting. This is Checkmate 032. This was a phase 1-2 study that investigated either nivolumab at different doses, as you see here, or in combination with ipilimumab, also in different doses. This was a non-randomized study that looked at 216 patients. And at the time, this showed very encouraging results. The response rate, as you can see here, varied from 10% when you use nivolumab monotherapy to 23% when you combine nivolumab with ipi at the higher dose of 3 milligram per kilogram. Also importantly, the 1-year overall survival rate was very promising and encouraging at the time. As you can see here, the 1-year overall survival rate for patients with relapsed small cell lung cancer varied here from 33% to 43%. But importantly, you do see higher grade 3, 4 toxicities when you combine nivolumab with ipilimumab for patients with small cell lung cancer. Looking here at Checkmate 032, and again, very important to note, the overall survival at the 2-year landmark analysis was quite encouraging. You see here with nivo monotherapy, you see the 2-year OS for nivo monotherapy was 14%, whereas for nivo plus ipi, that was 26%. So this was considered highly encouraging, and this actually led to the approval of nivolumab in the relapse setting for patients with small cell lung cancer. And this was basically approved based on durability of response, which I didn't show here. And then looking at another study that also led to the approval of pembrolizumab for patients with previously treated small cell lung cancer. This was actually a pooled analysis of 2 studies, Keynote 028 as well as Keynote 158. These were 2 single-arm studies in patients in the relapse setting as well. Here they included 131 patients with a median follow-up of 7.7 months. And again, overall response rate around 20% with the median OS of 7.7 months. And again, the durability of response was really what stood out, as well as looking at landmark analysis at 1 and 2 year, comparable overall survival that looked promising compared to historical controls in the previously treated setting, also led to the approval of pembrolizumab for patients in the previously treated setting. However, there is high attrition in extensive stage small cell lung cancer, and I think this is important to kind of think about development of new therapies. Looking, for example, at this data in the prospective setting, I think it's very important to note that only about 50% of the patients receive second-line therapy. And then an even smaller number of patients receive third-line therapy. We see here about 22%. And if you look at the IMpower 133 data, which was a global study, that number of patients that received second-line therapy and third-line therapy actually looked lower than what we're seeing here in this analysis. So again, I think it's very important to think about the impact of the treatments that we have, and certainly the chance that we have to make an impact in the second-line and third-line setting based on the biology of the disease and the resistant mechanisms that develop with further therapies in this patient population. And so here's Checkmate 331. This was a highly awaited study looking at patients with small cell lung cancer in the recurrent setting after platinum-based chemotherapy. And here, as you can see, patients were randomized 1-to-1 to nivo versus the standard of care, topotecan or amrubicin. The primary outcome of this study was overall survival. And disappointingly, this study was actually negative. So this study, as you can see here, the overall survival was no different between the 2 arms, and in fact, slightly lower for nivolumab. And then looking at Checkmate 451, this study was also a randomized phase 3 maintenance study that enrolled patients with extensive stage small cell lung cancer who had stable disease or better following frontline platinum-based chemotherapy. Patients were randomized 1-to-1 to nivo plus ipi versus nivo versus placebo. The primary endpoint here was also overall survival. Again, disappointingly, the study was negative. There was no benefit in adding Nivo plus Ipi in the maintenance setting compared to placebo, and there was no benefit of adding Nivo versus placebo in the maintenance setting. As you can see here, looking at this slide, for the overall survival, the Kaplan-Meier curves really are overlapping, and the 1-year OS for both arms was in the order of 40%. So again, this was a negative study, and this actually led to removing the approval of nivolumab for patients in the relapse setting, along with the results of Checkmate 331. And now we've also seen the removal of pembrolizumab approval for patients with small cell lung cancer in the relapse setting. And here's IMpower 133. IMpower 133 was the first frontline phase 3 study that showed a benefit with the addition of immunotherapy to chemotherapy in patients with extensive stage small cell lung cancer. This study enrolled patients with good performance status, and patients had to have treated asymptomatic brain mets. These patients were randomized 1-to-1 to atezolizumab, a PD-L1 inhibitor, in combination with chemotherapy at standard of care doses versus chemotherapy in combination with placebo. Following induction, 4 cycles every 21 days, patients were then randomized to maintenance strategy in the experimental arm to atezolizumab until progression or loss of clinical benefit, and in the control arm, patients went on to receive placebo maintenance. This study had 2 co-primary endpoints of overall survival as well as investigator-assessed PFS, and patients were stratified according to sex, performance status, as well as the presence or absence of brain mets. And we've seen these results that showed a progression-free survival benefit with the addition of atezolizumab to chemotherapy. And as you can see here, the median progression-free survival was slightly higher in the atezolizumab-containing arm, 5.2 months versus 4.3 months. But also importantly, you can see here the landmark analysis at 6 months as well as 12 months, showing a significant improvement in the 12-month PFS of 12.6 versus 5.4, and this was statistically significant. In addition, we also saw that there was an overall survival benefit. Again, numerically, there was an improvement in the median OS. This was a modest improvement that was statistically significant. And again, I think also looking at the overall survival landmark analysis at 18 months, looking at 34% versus 21%, with a median follow-up of 22.9 months. Importantly, looking at the safety results, as previously stated, the majority of the toxicities actually were hematologic in nature that were very similar between the 2 arms. And overall, the addition of atezolizumab to chemotherapy didn't add a significant or concerning level of safety or toxicity to this regimen. And you can see here, as expected, there were higher rates of immune-related AEs for the atezolizumab-containing regimen. But remember, this was also a placebo study. This was double-blinded, so as you can see, that's probably why there is some immune-related AEs in the placebo arm as well. And so the median duration of treatment with atezolizumab was 4.7 months, and the dose intensity for chemotherapy for both groups was very similar. Looking at the Caspian study, this study also led to the approval of immunotherapy in patients with extensive stage small cell lung cancer in the frontline setting, again, combined with chemotherapy. This study had a similar study design, included patients that were treatment naive with good performance status, and these patients were randomized 1-to-1 to the combination of durvalumab, the PD-L1 inhibitor, with tremelimumab, the CTLA-4 inhibitor, in combination with chemotherapy, followed by durvalumab maintenance until progression. The second arm investigated the addition of durvalumab to chemotherapy, followed by durva maintenance. And the third arm was the combination of chemotherapy. And a little bit different here, patients in the control arm could receive either cisplatin or carboplatin, and in the control arm, PCI was optional. The primary endpoint of this study was also overall survival. And as shown here, this study did meet its primary endpoint of overall survival, showing very similar results, in my opinion, compared to the IMpower 133. And again, looking at the landmark OS analysis, you see here, importantly, 32% in the durva-containing arm versus 24%. And this benefit seems to continue on, as you see in the 24-month probability of OS. Again, numerically, a modest improvement in OS, but when you look at the percentage alive at 18 and 24 months, I think that appears meaningful, and you can see the tail of the curve there, and we'll need longer follow-up. So here is the PFS of durva plus EP versus EP. And again, here the PFS is numerically very similar. And then looking at the durva plus tremi plus CP versus durva plus EP versus EP, this is actually to show the combination arm of durva plus the CTLA-4 inhibitor. That arm actually did not meet the primary endpoint. This was a negative arm in the study. Numerically, you do see that the combination of durva plus tremi plus EP seems to lead to similar OS results at different time points at 18 and 24 months. However, this arm did not meet statistical significance and should not be used outside of a clinical trial setting. Looking here at the progression-free survival, again, the durva plus tremi plus CP arm, numerically there was a slightly lower PFS and median PFS in the combination arm versus EP. The hazard ratio here is 0.84. And looking at the safety results, the addition of durvalumab to EP really, again, I think mirrors what we saw in the Empower 133 regimen. There was no significant toxicity or safety signal. Again, as expected, slightly higher rates of immune-related AEs, but the majority of the immune-related AEs for both regimens is actually grade 1 and 2 in nature, and the regimen is well tolerated. And we now have a lot of experience with immunotherapy plus chemotherapy in this patient population. When you look at the durva plus tremi plus EP arm, you do see higher rates of toxicity, including higher rates of grade 3-4 adverse events, as well as doubling of the discontinuation, and also higher rates of AEs leading to death. So again, I think outside of clinical trial setting, durva plus tremi plus EP should not be used in clinical practice. So here is where we are at in the frontline setting with the use of chemoimmunotherapy. The approval in Empower 133 was in March of 19, and the Caspian regimen also led to FDA approval in March of 2020. We had two other major studies, Keynote 604, which also looked at the addition of pembrolizumab, a PD-1 inhibitor, in combination with chemotherapy. That study completed accrual and showed a progression-free survival benefit, however, did not meet the primary endpoint of overall survival. But when you look at the Kaplan-Meier curves, they very much mirror what we saw in Empower 133 and Caspian. We also saw the results of the EA5161, which was an ECOG-ACRIN study, which was in the randomized phase 2 setting, which met its primary endpoint of PFS as well as OS, and is an acceptable backbone moving forward to investigate other combinations with immunotherapy, chemotherapy, and novel agents in small cell lung cancer. We talked about immune-related AEs, how the majority were grade 1 in nature, but certainly as you treat patients with small cell lung cancer and other patients with immunotherapy, it's very important to really monitor patients very closely for development of immune-related AEs. And certainly the most common ones are rash and itching, as well as thyroid abnormalities. But certainly it's very important to monitor closely for early detection so that treatment can be reinstituted with the chemotherapy, immunotherapy agent if patients are benefiting and in a safe manner. Pneumonitis is a complication of immunotherapy and immunotherapy in combination with chemo that, of course, is feared by both patients and clinicians treating. This is a patient with diagnosis of small cell lung cancer. Here you can see on the CT scan that at baseline, this patient had a mass in the right lung and then subsequently had excellent response to therapy, however, developed dyspnea on immune checkpoint inhibitor therapy and now has ground glass opacities and was diagnosed with immune checkpoint inhibitor therapy pneumonitis. We do have grading and general recommendations for how to manage immune-related AEs, and certainly for the use, for example, of steroids as a way to manage immune-mediated adverse events, and specifically managing patients with pneumonitis. I think it's important to use the grading because it really does help you, number one, decide whether the patient can be treated safely as an outpatient or inpatient, and when to start steroids. So starting steroids at grade 2 pneumonitis or higher, admitting the patient for grade 3 for pneumonitis or higher grade pneumonitis is certainly very important. And I think it's also important to get multi-D teams on board and consider a bronchoscopy to exclude other potential etiologies before calling it a pneumonitis if that is possible to do when the patient is clinically stable. And certainly if patients do have grade 3 or 4 pneumonitis, it's very important to monitor closely as you're tapering the prednisone, making sure there's no flare. And unfortunately, with higher grade toxicity, such as grade 4 pneumonitis or grade 3 pneumonitis, challenging with an immune checkpoint inhibitor may not be possible and is contraindicated. So can we select patients? And I think really for the regimens that we've discussed so far, both the Empower 133 and the Caspian studies, they really looked at biomarkers as best as possible. We know that in patients with small cell lung cancer, obtaining tissue at diagnosis enough to be able to do biomarker studies has been challenging in the clinical trial setting. And so the biomarkers that were performed were not done in all patients, but here's a subset analysis of Empower 133. This has now been published, really showing that, number one, that for the patients that we did do biomarker testing on, it really didn't matter whether patients had PD-L1 expression of, positive or negative. All patients overall seem to benefit from the addition of immunotherapy to chemotherapy. And I think it's also important to note that PD-L1 high expression is actually a rare event in small cell lung cancer. And then looking at PD-L1 expression in the Caspian study, similarly, again, I think the most important take-home message here is to say that for PD-L1 expression, this is not a predictive biomarker, and all the subgroups did benefit from the addition of immunotherapy to chemotherapy in the Caspian study, irrespective of PD-L1 expression. We also looked at blood TMB, and blood TMB had been shown to be potentially predictive for progression-free survival in monotherapy studies investigating atezolizumab in the second-line setting in non-small cell lung cancer. And looking at different cutoffs, 10 and 16, we looked at that in the Empower 133 study. And using the cutoff of 10 or 16, again, there was no significant predictive benefit here of using blood TMB. And again, this showed that all patients benefited from the addition of atezo to chemotherapy. So no significant benefit of using blood TMB or PD-L1 expression in small cell lung cancer at this time. Looking ahead in terms of future considerations, certainly the addition of immunotherapy to chemotherapy has led to improved overall survival and has definitely been an advance in the treatment for our patients. And we certainly know that there are subsets that significantly benefit more from immunotherapy. However, the benefit is modest for the large majority of patients. So it's very important to look at other investigational combinations. This is the Skyscraper 02 study, now in the phase 3 setting, adding an agent called tiragolumab. Tiragolumab is an anti-TIGIT antibody in combination with atezolizumab and carboplatin etoposide in the randomized phase 3 setting. The primary endpoints of this study include PFS as well as OS. And this study is actually ongoing and has completed accrual. Other important efforts that are ongoing, and I'll name just a few, and this is certainly not fully representative of all the ongoing studies in small cell lung cancer, is looking at the addition of immunotherapy now in the limited stage setting. So can we improve cure rates in limited stage by adding immunotherapy to combination of chemoradiation in patients with limited stage small cell lung cancer? There's an ongoing effort with a study by the NRG Alliance Group, the LU005, combining atezolizumab to chemoradiation, followed by atezo maintenance versus chemoradiation alone. And this study is also ongoing, and we look forward to seeing the results. We've also seen the ongoing efforts with the Adriatic study. This is a study investigating the addition of durvalumab or durva plus tremi, and now in the consolidation setting after a combination of chemoradiation in patients with limited stage small cell lung cancer. So let's revisit our case. I'll review very quickly. This patient was a 72-year-old man who was admitted for severe shortness of breath and oxygen requirements, the right lung mass, the bulky mediastinal adenopathy, multiple liver mets, and 2 brain mets. So based on our discussions, what is the first-line treatment of choice, and which one would you treat first in terms of areas of involvement. This patient has extracranial disease, but also has 2 brain metastasis on imaging here. And let's talk about whether or not you'd add trilaciclib now that we have the new data.
Yeah, so thank you so much. That's for taking us through that whole first line. That's a lot to go through, and some really big advances. So this is exciting. So let's Dr. Leal, maybe I'll start with you on this. First line treatment, patient is in the hospital, 2 brain mets, extensive disease, short of breath. Take us through your thought process on this and how you'd go about treating this person.
Sure. I mean, I definitely would want to know a little bit more about this patient. Definitely would want to know performance status, comorbidities, and also, whether or not there are bone mets and significant laboratory abnormalities. Is there organ dysfunction? Want to see what that CBC looks like. Creatinine, liver function tests are very important. I'd probably also just make sure that I wouldn't have to be worried about tumor lysis syndrome, which you don't see a whole lot, but I do still like to check if there's a significant burden of disease, which this might suggest with the bulky mediastinal as well as multiple liver mets. In my opinion, without knowing more about this patient, if the 2 brain mets are not associated with neurologic symptoms and are in areas that are sort of safe to first try chemotherapy in the frontline setting, I certainly would treat this patient in the hospital with the combination of carboplatin and etoposide. In the inpatient setting, we've had trouble getting coverage for immunotherapy. So if that was the case, this patient would have to receive immunotherapy with cycle 2. So I would probably delay radiation to the brain mets and repeat the brain MRI with cycle 2. And we also know that platinum etoposide does seem to have some CNS penetration, and certainly would talk to the patient about being careful in terms of if they develop neurologic symptoms to let us know right away.
Yeah, and thank you. I purposefully left it a bit vague to allow room for discussion as we can adjust some of the details. But you highlighted, I mean, you kind of broke it down really well. So let me ask, so you said that generally you start with the chemotherapy alone in the inpatient setting, and I think that's common. Do you have any concerns about that? I mean, do you have any worries about that working less effectively than getting the immunotherapy with cycle 1?
I've thought a lot about that, and here are my ways of sort of being comfortable with this plan, with the reality of what we have in terms of coverage for our patients at this time. When patients are this sick with significant bulky disease, really what they need is chemotherapy in the sense for the short term, they're really going to see that benefit with the chemotherapy. When you look at the results of both Empower, Caspian, and the 2 other studies I mentioned, Keynote 604 as well as EA5161, really there isn't a whole lot of addition in terms of response rate with immunotherapy to chemotherapy. So in terms of control of symptoms and reducing burden of disease, really chemotherapy is what will do that. In terms of the overall survival benefit, 1 cycle less of the triplet combination, would that be something that could lead to a detrimental outcome? I guess we don't have an answer to that, but if it's possible and patients are robust enough, I might try to add another cycle of triplet so that they can have 4 cycles of the triplet combination. Another thing to think about is, patients with poor performance status and patients that were admitted to the hospital that are sick enough that need to be treated urgently or emergent, these patients were not included in any of these studies. So again, I think this patient has very unique needs, and I think we need to meet those needs first.
Yeah, that's a really excellent point. I mean, we're taking clinical trial data and we're extrapolating it out to all patients. I think when I've thought about this too, I don't really see any suggestion of separation of the curves until you're out about 5 months. So I don't see any reason to suspect that you're necessarily having patients respond because of adding the checkpoint inhibitor, or, in someone who's not going to benefit from the chemo, it just seems unlikely that that's really going to make the difference. And in someone with so much going on that they're requiring the inpatient setting, all of your comments on that are very appreciated. Dr. Weiss, as far as the brain mets, so Dr. Leal painted a scenario, did mention that if the brain mets aren't causing any kind of neurological changes and such, but let's where is that line? I mean, at what point do you consider addressing the brain? Take us into kind of the more challenging aspect of what those brain mets can do and how that might impact your treatment.
Sure. So I think it's not a question of risk-benefit so much as risk-risk. Dr. Leal nicely outlined that that you've presented to us a patient with severe shortness of breath and a new oxygen requirement, and you've given us nothing scary about the brain mets. And this is actually relatively common in clinical practice. This is not a niche case. Of all solid tumors, small cell is perhaps one of the most commonly treated inpatient, and it's because of central chest syndromes. Most commonly obstruction of central airways, but also obstruction of central vessels. So this is actually a relatively bread and butter case. And I absolutely agree that chemo works in small cell, right? Its weakness is that it doesn't last. But in the short run, you have a suffering patient in danger from, I'm going to presume airways here. I'll play the stats on that. And chemo actually does help. You give that person the first cycle of chemo, and you're going to see regression of that tumor. You're going to see improvement in their breathing. And so that's the easy part, that starting with chemo is absolutely the right thing to do. I would parenthetically note, you could talk about radiation, you could talk about stents. Frankly, in small cell, that's not my usual maneuver either. I very much agree that chemo works. It's quick and easy to get going, and it makes great sense here. Now, what you challenged me on subsequently is what's the dividing line for scary in brain mets? And guidelines love to define what is scary, right? If you look at NCCN on oligometastasis or oligoprogression, they try to define what scary is. I think it's kind of, you know it when you see it. Now, I'm not going to completely dodge your question. Dr. Leal already mentioned symptomatic, right? So if the patient is neurologically compromised by brain mets, that's not a brain met you can sit on. That's one that needs urgent action of some kind. Doesn't mean you don't go first with chemo, but it does, if you have such a high risk as presented here, a patient's shortness of breath, a new oxygen requirement, but it would mean that you might have to follow that chemo in relatively short order, perhaps with stereotactic radiotherapy. Now, there's a gray zone in between. There might be a patient who is neurologically intact, perhaps even completely asymptomatic on a real neuroexam, which, by the way, is not the typical internist or oncologist neuroexam, but a real detailed neurologic exam. They're fully intact, but when you look at the lesions radiographically, you see features of concern. Perhaps that concern is edema, some midline shift, a little bit of bleeding. These are features that, again, might increase your concern to say, I can't totally wait on this. This isn't a patient that I'm going to hope the chemotherapy has efficacy in the brain, but this is a patient where I probably want to action this as soon as it's deemed safe. Now, you appropriately bring up that this is a continuum. There's no clear rubric. And so what do you do with that in practice when you're there on the wards with this patient? And the answer is you talk to colleagues. This is what multidisciplinary tumor boards are for. This is what we at my institution, and I think many others, we have cancer neurology tumor boards. I forget what they call it at my place, but the gist is you have your neuro-oncologists and neurosurgeons and your neuroradiologist presence in the same room to help you answer that question. How scary is this one? Should I wait for that first scan to hope the chemo works? Do I need to treat this right away? Do I need DEX? Or is this one I'm going to push to do hypofractionated radiation pretty urgently after chemo? You don't have to decide that alone in a vacuum.
Yeah, so nuanced scenario. Thank you for going through your thoughts on that, on the spectrum of that. Now, you talked quite a bit on trilaciclib, and this is trilaciclib, I'll admit, I've really debated in my mind quite a bit. And you gave a pretty compelling discussion about trilaciclib. I found the quality of life aspect of the data to really be the more interesting. I think some of what I hadn't fully anticipated, actually. The cytopenias, I did, but the fatigue, I liked that you highlighted that because that's somewhat compelling. So, Dr. Leal, I'm going to pose this to you. In this case, we talked about a role. Is there a role for trilaciclib? What are your thoughts on that when we're talking about this clinical scenario with first-line chemotherapy?
You know, I agree with all the points that you've made, Dr. Sands, about using trilaciclib, and I confess that I have not used it yet. But Dr. Weiss, your presentation was pretty convincing. I will say that I'm going to start using it. I will say that we have older patients. Jokes aside, I think that the regimen with the carboplatin etoposide in the older patient population is a major challenge. You know, you start out and the gut reaction is, should I dose reduce up front? Because I'm just so worried that patient is going to bottom out on day 10. And so this is a real concern that we have, especially if patients start out with borderline counts because of anemia of chronic disease, or because they also have some degree of CKD, you know, they have heart failure, their kidneys are just not at their usual, you know, normal levels that another patient with less comorbidities may have. And so these are patients that are already coming in with high symptom burden, with some degree of organ dysfunction, comorbidities, and now we're adding, you know, carboplatin etoposide, which is a very highly myelosuppressive regimen in my experience, and the experience of many. So I do think that trilaciclib in that regard does add that advantage in terms of, you know, supporting patients throughout chemotherapy, and perhaps if there is a benefit in fatigue and, you know, less need for growth factor, these are things that add to the complexity of the care when you have to do it on the fly or when you have to do it in a non-scheduled way. And this is a way of kind of planning it out better and perhaps supporting patients better. I think one thing Dr. Weiss didn't address was cost. Is this something that we have to worry about for our patients?
Yeah, so, you know, I was thinking about, you know, while I've been listening to both of you talk, the thing on my mind, you're both too polite to say it, but the thing on my mind is, you know, when you investigate something, how much are you subsequently going to drink your own Kool-Aid? And I think one of the things that's made me passionate about this particular Kool-Aid is that it's a quality of life drug. And we give so much lip service theoretically to quality of life. And then sometimes we arbitrarily embrace things with minimal advantage, for example, fosaprepitant for nausea. And then at other times, there becomes a pro-con kind of argument. And I never, you know, I guess the humane aspect of that made me sort of fail to understand why this gets such a strong con argument. And I think you've brought up the most credible one, right? Which is at what financial cost? And I think I have two answers to that of why I'm going to keep chugging this particular Kool-Aid. One is that we're in the US, where that's actually not our responsibility at this moment in time. We think when you look at alternative models that will at some point become the case, and certainly our colleagues in pretty much the rest of the world have to be responsive to that. But if we're going to be honest, between the three of us and, well, I guess everyone listening to this, when we pay attention to cost in the US, really the only cost we actually pay attention to is the cost that the patient sees, not the cost of the healthcare system. And this is not endorsement so much as it is confession, at least of my own practice. Maybe you guys are better than I am as a citizen of the universe or of the country. But perhaps the better answer is that this does not necessarily increase cost. So what I didn't show was the cost of treatment of febrile neutropenia and of anemia. And the quick answer is that they're actually rather expensive events to treat.
Now, I mean, to speak a little more about trilaciclib, I think what I've seen discussed most in kind of the story of why it's an advantage is you highlighted the severe neutropenia difference. And that to me wasn't so compelling, given that if I'm concerned about someone having neutropenia, I would give them G-CSF. And so there's already something that exists, which in the trial, patients weren't initially allowed to be getting. So essentially acknowledging that it's not necessarily a huge problem in itself. But where I've used trilaciclib is particularly a patient who had severe thrombocytopenia, which you also pointed out, who does have a cardiac history and is on blood thinners. And so we're really trying to maintain a platelet count that's reasonable, around 50,000 and such. But he had really severe and prolonged thrombocytopenia. And that was the first patient I ended up using trilaciclib with. So one more question on trilaciclib, because we've talked about it a lot already. Dr. Weiss, with that whole thing about neutropenia, is neutropenia something that you've been generally really concerned with? Is GCSF something that you have utilized, or is it something that you'd add on? You mentioned that it could be used with trilaciclib, but is the neutropenia something that has really been a concern to you, or is it all the other stuff that you find so compelling?
Yeah, so this is not purely a neutropenia story to me. I think that's what we pay the most attention to as oncologists. I do think that the numbers there are quite nice. I would note that while Neulasta was able to be avoided in a number of patients in the trials, and I don't think Neulasta is a free ride. It's not a cheap drug either, and it can cause bone pain and other side effects in terms of the toxicity cost, as you phrased it. So I think avoidance of Neulasta actually is a desirable goal. But I would also note that in patients who ended up getting Neulasta layered on, the dual inhibition was actually rather effective. And I think there are patients who need that. But I would actually say that I find the fatigue data the most compelling to me personally. Not necessarily the anemia data per se, other than to the extent that it contributes to a clean story from mechanism to numbers to the quality of life data. I think that fatigue is really an underestimated problem by practitioners, how much our patients suffer from this. And this is the first time that I felt that I really have a powerful maneuver that actually does something about it.
Now we're going to go into a new case. This is to really discuss second line and beyond. So 68-year-old woman, 46 pack year smoking history, quit smoking 10 years ago, presented for yearly lung screening. This was the first year of getting lung screening. Scan showed left lung mass, left hilar adenopathy. PET showed significant FDG avidity, no other findings. Biopsy showed small cell lung cancer, treated with concurrent cisplatin and etoposide with radiation, with curative intent, and then got prophylactic cranial irradiation. And now 8 months later, surveillance imaging shows mediastinal adenopathy and bone metastases, and biopsy confirms recurrence. So keep that case in mind as we now jump into second line therapy. So the approved until very recently, the only approved second line treatment option has been topotecan. The dosing that is approved is either PO or IV, each of those day 1 to 5 of 21-day cycles. And here we see the curves. The PO on the left there was versus best supportive care. This led to approval with a chemotherapy-free interval of greater than or equal to 45 days. And on the right there was by IV. That was compared to CAV, in which in the trial they were fairly comparable. And chemotherapy-free interval of greater than or equal to 60 days. So there's a bit of a time difference in the chemotherapy-free interval for the approvals. Topotecan has not really widely been used, despite really being, for a long time, the only approved second-line therapy. I'd say it hasn't been as widely used as that statement would suggest. And really, I think a lot of that has to do with toxicities. It certainly has demonstrated cytopenias, also GI toxicities, particularly with the PO regimen, but really in both. Now, very recently, lurbinectedin has been approved as a second-line treatment option. Now, lurbinectedin, well, first of all, I'll say small cell lung cancer is a transcriptionally active disease. And so the mechanism of lurbinectedin really addresses that, as well as some of the tumor microenvironment. Lurbinectedin binds to promoters, binds transcription factors, and ultimately leads to cell apoptosis. Now, the approval comes from this Lancet Oncology publication, which came from a basket study, 105 patients with small cell lung cancer that were included. these patients were included even if they had a chemotherapy-free interval of less than 90 days, although that was the cutoff in calling resistant disease or sensitive disease. And different trials actually have a little bit of a different cutoff, but in this case, 90 days was how they were defined. As far as the efficacy, we do see a difference really between those in the chemotherapy-free interval of less than 90 days and those with the greater than 90 days as expected. But here on the top, we see the partial response overall was 35%. In the resistant disease, it was 22%, and it was 45% in those with the sensitive disease. Looking down at the bottom, the overall survival, the median overall survival being 9.3 months for all. In the resistant was 5.3 months, and in the sensitive was about a year. And when we look at the the progression-free survival, so go up one from the bottom, progression-free survival, when we look at the 6-month progression-free survival, in the resistant disease, it was 19%, and in the sensitive disease, it's 44%. So as we would expect, a trend to better responses and more durable responses in those with platinum-sensitive disease versus platinum-resistant, which is pretty comparable or pretty consistent with the cytotoxic drugs across the board. So here you see on the right is the swimmer's plot, and you can see that there are some patients out there with durable responses. We do see more from those with the platinum sensitive, but there is one in the mix there that despite being platinum resistant. And on the left side here, as far as the duration of response, notice that the axes aren't exactly the same in scale, so the resistant disease is actually a bit more of a drop-off than what it looks like compared to those with platinum sensitive. But we do see some patients, particularly in the platinum sensitive group, with some durability. And in these small numbers of patients, we do see a little bit of a tail out there with some durability to the resistant, but not nearly as much. Now, as far as the safety profile, this was generally very well tolerated. There were cytopenias. The neutropenia in particular, we see 21% with grade 3 neutropenia, 25% with grade 4 neutropenia. Despite that, only 5% of patients had febrile neutropenia. So although we saw pretty consistent neutropenia, febrile neutropenia was not as common. Otherwise, this was fairly well tolerated. We do see 7% of patients with fatigue. We do know that small cell lung cancer is something that also causes fatigue, and something that Dr. Weiss mentioned in his talk as well as something that's common. And challenging to treat. Now, that being said, I think when I saw this data, to me saying, well, the fatigue, hard to say, I kind of expect some fatigue in somebody with small cell lung cancer undergoing treatment. That being said, my experience has been that some patients really do experience pretty exceptional fatigue. And in the worst case, I actually had a guy where I had to completely stop the drug because of fatigue. At the same time, he did have ongoing 4 months, a little more than 4 months, of ongoing disease control even after stopping the drug. And so he had just gotten a few doses before we had to stop it, but then had ongoing disease control for some months. Now, this isn't something that comes up on everybody, but it did validate for me that in fact the drug in some patients does cause significant fatigue. Now, that being said, the Atlantis trial, the combination lurbinectedin plus doxorubicin versus dealer's choice of topotecan or CAV, this trial, we do have a press release reporting it as a negative trial. So that was disappointing given the prior data from the basket trial and the enthusiasm around lurbinectedin. The combination itself was negative. Now, I'll point out that the lurbinectedin dose was less than in the single-arm study. Also, topotecan and CAV are active drugs. So although the toxicities of topotecan and CAV, I think, limit the use, these are drugs that do have some efficacy. So it will be interesting to see the data when it does come out, but that combination is reported to be negative. There are multiple ongoing trials with lurbinectedin that are listed here. I did point out that cytopenias and particularly neutropenia were really very common. And so, Dr. Weiss, I will pose the question to you, can we combine trilaciclib with lurbinectedin? And what are your thoughts on that? And add in any comments you have on lurbinectedin as well.
Yeah, so I fundamentally agree with the description of lurbinectedin. I would comment it's a bit better than topotecan in the data, both for efficacy and for tolerability. And I think it's become the favored next line option, at least in the US, after carboplatin, etoposide, and a PD-L1 inhibitor. We don't yet have an approval or safety data in the combination with trilaciclib, but the question you ask is an important one, because if you look at the toxicities of lurbinectedin, they're also hematologic, just like topotecan. So it's a natural question. The other driver of asking the question is the dose difference that you mentioned between Atlantis, which failed, and the single agent trial, which we're all looking upon as favorable. There was a subsequent analysis in a poster in World Lung 2020, although it was actually January 2021, thanks to this little virus thing. But at any rate, what they showed at that conference was they did a PK analysis of patients across their trials, and they showed that in the patients who had the appropriate or the optimal exposure, which happened to be an AUC of 1400, the response rate was actually quite a bit higher if you hit that AUC or higher, and with a pretty sigmoidal curve to the left of it dropping off if you didn't reach that level of exposure. So with our existing agents, dose intensity doesn't seem to matter a lot, but the Atlantis experience, as well as the data on that poster, to me would argue that maintaining a full and non-reduced 3.2 milligrams per meter squared dose may matter for improving treatment-related outcomes from lurbinectedin. And so these are the two reasons that we're actually asking the question. And the first draft of that protocol is nearly completed, and I look forward to getting it open and being able to actually answer the question you ask.
Great, thank you. Now, for the sake of time, I am going to go a little bit quickly through other second-line options. These are not approved, but commonly utilized. And I think it's important to highlight these, because I will say, with small cell lung cancer, we've highlighted that patients often come in symptomatic and first-line treatment works really well, but then they have progression. And at progression, it's a totally different clinical scenario. It's often resistant disease. It's challenging to treat. And I think due to that reason, there are some oncologists that end up not really providing other treatment to patients. And I've seen patients who have come in for kind of that last ditch effort, reaching for the stars. Is there anything out there where I'm not ready for hospice, that had only gotten first-line treatment, and their oncologist have then recommended hospice, and so they come in saying, is there anything? And there are things. So even after second-line treatment, depending on the patient, there are patients that I've given all of these treatments to, depending on the individuals. And so I'm going to go through these a little bit quickly, but I do think it's important to acknowledge these as also being treatment options. So irinotecan, topoisomerase 1 inhibitor, prevents religation of the cleaved DNA strand, leading to DNA damage and cell death. Now, the data for irinotecan in small cell lung cancer, these that we're going to go through in many cases, it's not a huge number of patients, and the data is really from years ago. So in this case, we're talking about 15 patients. The median duration of response in this study was 58 days, and median overall survival being 187 days. Now, as far as the tolerability to irinotecan, I do find that this is often well tolerated. Diarrhea is certainly something that can happen with irinotecan. Some of these older studies, when we're looking at nausea, vomiting, the antiemetics that we have now really reduce that. So something to consider when seeing these numbers. Paclitaxel, this was a compound initially isolated from the Pacific U, binds to microtubules, promoting microtubule assembly and preventing disassembly. So this inhibits cell replication, interfering with late G2 mitotic phase. And there are two different dosing schedules for paclitaxel. There's the 175 milligrams per meter squared every 3 weeks. That's really what is commonly used in non-small cell lung cancer as well. And then the weekly dosing, and this is what I tend to lean toward, is this weekly dosing of paclitaxel, which is generally better tolerated. And from the data, I mean, in both cases, this is 21 patients, but we do see responses. You can see on the right side here in the weekly dosing, the total was 5 patients out of the 21 with a partial response, so a 24% response rate. As far as the toxicities, with the weekly dosing, as I mentioned, this is generally very well tolerated. You can see that the grade 3-4 is for the most part really just related to cytopenias. Temozolomide is another treatment option. This is a prodrug, rapidly converts to an active metabolite. The unique thing about this is that there's significant penetration of the blood-brain barrier. So in someone who's gotten whole brain radiation and then ends up with progression in the brain, and then have that discussion, well, can it be radiated again? And that adds more risk in that scenario. And certainly in cases, sometimes it can't be treated by radiation again. And so that's a scenario where temozolomide might be more efficacious. So the dosing of temozolomide, there have been a couple different dosing schedules for this as well. The more established one has been the 75 milligrams per meter squared per day for 21 of 28 days. It is important that these patients get on ondansetron 30 minutes prior to the dose because there can be some nausea associated with it. In this study, sensitive disease and refractory disease, they used a 2-month cutoff. But you'll see there, it's not everybody, but on the right side of this, you do see patients with partial response, and in this case, there was one complete response. These are the curves, and as expected, as we see consistently, those with more platinum-sensitive disease tend to be more responsive with more durability when we add in other cytotoxics. The other dosing schedule is the 200 milligrams per meter squared per day for 5 days. And with this dosing, there was less cytopenias in particular. Here we see the waterfall plot. It wasn't as many patients in this study as the other dosing, but we do see partial responses, including both refractory and sensitive disease. As far as the toxicities, I've mentioned that we saw less cytopenias with the 200 milligram per meter squared per day dosing. I think the thought on these is that they're generally pretty comparable. On the left side there, I have the differences in the data. This is a hard cross-trial comparison of data. The responses were 20% in the 75 milligram per meter squared dosing and 12% in the 200 milligram per meter squared dosing. But the number of patients with sensitive disease was different in the trials as well. So the trial that had more responses also had more patients with platinum sensitive disease. And so one could attribute it to that. For me, if I have patients that are still pretty robust, where I'm not as worried about cytopenias, I do tend to still use the 75 milligram per meter squared dosing. In somebody where I'm a little more concerned about that, I might use the 200. So 68-year-old woman diagnosed with recurrence of small cell lung cancer. It's 8 months after having completed the concurrent chemo radiation. So obviously this patient did not get an initial checkpoint inhibitor. Somebody with a good functional status, labs all look good, no significant comorbidities. So Dr. Leal, I've really cleaned this one up with those statements. What would you consider treating with now in the second line setting?
So this patient, I would actually argue that she should be treated like a first line patient. This patient was a limited stage at diagnosis, correct?
That's right.
So at this point, this patient hasn't received a platinum in combination with immunotherapy in the advanced setting. And I know that in small cell, we don't have a defined way of calling somebody platinum sensitive versus platinum refractory. But I would say that from a clinical standpoint, we tend to consider using rechallenge with a platinum if they've had 6 months or greater since their prior platinum. And so for this patient who's 68 with good functional status, I think a platinum re-challenge would fit here in combination with immunotherapy. So this is a patient that I would consider starting carboplatin etoposide in combination with atezolizumab or durvalumab. And certainly if there's a clinical trial, I certainly would consider that as another option as well. Some trials, though, do want a year between platinums, so that could potentially exclude this patient. So if this patient had significant issues with their prior platinum, meaning they absolutely cannot tolerate another platinum, that may be something that you would skip the platinum etoposide. But if it was related to the etoposide, you could consider platinum in combination with irinotecan, which isn't our usual standard in the front line. But again, I think this patient, I would certainly try the platinum again. And then, there's no data with the platinum irinotecan with immunotherapy, so that would be something that would fall short there.
Yeah, this is something I hear reasonably debated. I mean, after having gotten the radiation as well, what you end up calling platinum sensitivity, as you outline, this is kind of an area for debate. Dr. Weiss, where is your line on that? And would you also consider retreatment with platinum etoposide? Dr. Leal is doing platinum etoposide plus one of the checkpoint inhibitors. But where is that line for you, and how would you treat this person?
Yeah, so I agree there's no absolute line, although I think that the major two dividing points to talk about are 6 months, which is the most common dividing line in the US, and actually 90 days, which is the most common dividing line for those on the other side of the pond. And so at 8 months, even though there was radiation used before, I think this is still a platinum sensitive patient. I think I agree with everything stated already that is an option for this patient. I would point out two additional things though to comment on. One is that if you look at data for lurbinectedin, as well as for other agents, patients who are more platinum sensitive are also more likely to derive good benefit there. And we don't really know that whether lurbinectidine or a platinum etoposide rechallenge with PD-L1 is going to work better. The other thing is that this gets very funny, the language if she's focused on quality of life. It's not that your case is bad, because actually we hear that from patients a lot. It's that we need clarification from the patients about exactly what that means, and it needs to be a conversation. Because I think when patients equilibrate quality of life with avoidance of toxicity of therapy. And I do agree with them. That's at least half of the battle. The other half of the battle is preventing suffering from the cancer. And small cell is a very, very symptomatic cancer. And so I think that deserves a little bit more conversation. But if at the end of that conversation, the patient asked what I would do for myself, it would be along the lines of platinum etoposide and a PD-L1 inhibitor. And as I'm sure you could guess, I would precede it by trilaciclib.
Yeah, so I love that I put that language in there specifically because that comes up so much. And also, I started out by saying that I see patients that don't end up getting treated and put on hospice when there are treatment options for them. And I think that language is something that ends up leading people into not getting treated, when in fact, I strongly agree with you that the cancer itself causes toxicities, causes impacts on quality of life as well. And so balancing these is a nuanced discussion. And I love your answer to that, in that really helping patients understand what specifically they mean by that, and maybe teasing apart some of those preconceived ideas.
Yeah, patient values absolutely trump at the end of the day, but it's part of our job to educate the patients so that they can plug their values into that and to engage in an education and conversation effort.
I also do want to add in terms of the gray zone with the immunotherapy, but I think with where the data is right now and the opportunity to add immunotherapy that has improved survival, but hasn't done that in the second and third line setting as far as we know, if you move on to straight second line for this patient, you're losing the opportunity to incorporate immunotherapy in a setting where it may potentially improve her survival. So I think that's another reason to add the immunotherapy and add a triplet there at the get-go and calling it platinum sensitive, given that it's been 6 months and greater. The other thing I would add about quality of life is also the fear of what is coming. Somebody who's had limited stage small cell lung cancer and now their cancer has recurred. I think the fear there is, this cancer in that person's mind may be that they think this is not curable and equate that with treatment is not going to add much to my life expectancy, my quality of life. And what's the point? And again, I think I agree completely. It's an important quality of life discussion and trying to understand values, but also trying to also explain to the patient what the opportunities are in terms of therapies and what kind of supportive care they can receive to get safely through chemotherapy and immunotherapy and other therapies to the point where they can extend their life in a meaningful way to them.
Yeah, great points. So let's jump into some of the future directions, because there's a lot happening right now in small cell lung cancer. So one of the things as far as a backdrop of what's going on is small cell lung cancer subtypes. And really we've seen this from Charlie Rudin's lab at Memorial Sloan Kettering and Carl Gay and Lauren Byers at MD Anderson. Each of them have proposed these small cell lung cancer subtypes that I've just clicked through. And the proposal being that actually these subtypes may respond differently to different therapies and therefore can serve as a backdrop in our clinical trials going forward by recognizing the subtype and finding the more ideal therapy for each of these. So an exciting thing where potentially small cell lung cancer becomes a little bit more like non-small cell in being able to define subgroups and therapies that might be more effective for each of them. Also within this is looking at PARP inhibitors. And we see on the left here is olaparib with temozolomide. This showed a promising 42% response rate, progression-free survival of 4.2 months, overall survival of 8.5 months you see there. And below that, talazoparib plus temozolomide, the combination with a different PARP inhibitor. And then on the right here, we see Schlafen 11 expression really seems to suggest a greater likelihood of response to PARP inhibitors. And that is something that's now being incorporated in trials. We see on the top left here, the atezolizumab plus talazoparib maintenance trial that's specifically in those that are Schlafen 11 positive. Another promising trial, liposomal irinotecan, and here you see the data from the phase 1 with different dosing with response rates, 43% partial response rate. And the bispecific T-cell engager here, DLL3 and CD3, so this is binding T-cells and binding small cell lung cancer, bringing them together to lead to an immune response. And Dr. Wanikoko just presented an update on that at ASCO as well. This has been another promising therapy. Dr. Weiss, do you want to take us through the Amgen 757 data, as well as any others that you're particularly interested in?
Yeah, so I think we have a luxury in small cell that we don't have that often in solid tumors, which is that we do actually have preserved neoantigens, that the majority of small cells are going to express. In contrast to most solid tumors where the neoantigens are all private, which is to say if all three of us got cancer tomorrow, most of our neos would be different. One of these preserved targets is DLL3. The failure of the antibody drug conjugate Rova-T is quite famous. Actually, the drug was active. The toxicity just wasn't worth it, in my opinion, probably due to the toxic payload and its properties more than to failure of the target. And so now there are two new attempts to action that target. AMG 757, now known as tarlatamab, is a bispecific engager. There's also a CAR T trial that I believe is on hold due to toxicity, but I think still has promise. This was shown in, I believe, poster discussion just very recently at ASCO. There was a lot of conversation around the toxicity, but actually when you divide it out, most of the toxicity was low-grade CRS, meaning no hypotension that needed anything more than fluids, no hypoxia that needed anything more than oxygen you can deliver in clinic. The grade of, and so that may be a profile that's new to clinicians, just as, and is therefore a little more scary, just as the toxicity profile of PD-1s was new and once scary to us. But in terms of things that patients carry around with them after they leave your infusion room, I actually thought it looked reasonably favorable. There was a single grade 5 pneumonitis event, a single grade 3 encephalopathy event. Again, a very cellular therapeutics kind of feel to it, but the drug's active. As you see at the top right, response rate of 20%, not shown well here, but I'll just briefly mention that as you get to the higher doses, it looked more like 30-something%, and a DOR of 9 months, with the patients at the highest dose really having immature data to let us know how long it's going to work. And then really briefly, I think GD2 is also an interesting target. The antibody against that, dinutuximab, also had pretty unimpressive data when tried in small cell, but I am aware of a CAR T in development against the target. The preclinical data has been shown at Santa Monica lung, and I'm aware that a phase 1 study is being prepared. One thing interesting about this construct is that it has an inducible caspase kill switch, and so if the toxicity is unacceptable, there's a way to turn it off.
Yeah, it's exciting. There's so much. I mean, there are so many other things that we could go through: aurora kinase inhibitors, BCL2 inhibitors. Dr. Leal, anything that sticks out to you? Not limited to what we've discussed. There are so many other things going on as well. EZH2 inhibitors. What are some of the things that you're most excited about? The trials that are ongoing at this point.
There's an ongoing trial, the LU007, looking at radiation in combination with immunotherapy versus atezo maintenance for patients with small cell lung cancer. So radiating up to 5 sites of disease. So consolidation radiation after induction with chemoimmunotherapy, I think is a very interesting concept, a very interesting trial, and really interested to see how that contributes, and can we see synergy between radiation and immunotherapy in that setting. So that study is ongoing. Another interesting trial that I think I'm very excited about, and we'll see some results hopefully soon, is actually the combination of a drug that at this point is numbers and letters, but it's a BMS compound. It's an agent that is anti-fucosyl GM1 antibody that is now being investigated in combination with chemotherapy and immunotherapy in a randomized phase 2 setting in the front line. This combination actually was studied with atezo and showed promising duration of response compared to historical controls. And then they also investigated the combination with platinum chemotherapy, and again saw safety and interesting activity. And so now this study is looking at the combination altogether in the frontline setting. So I think that's another interesting study that I look forward to seeing some of the results. And I agree with you, a lot of interesting things that are up and coming that we could talk about, but certainly need to continue to improve in the frontline setting. As we saw the attrition rate, I really focus in the front line because I think we have to give the best therapy up front to really allow better overall survival, better quality of life for patients from the get-go.
Yeah, that's very well stated. So we'll limit the discussion a little bit in this setting because we are running out of time. I will just point out, I think in all of this, it's a little beyond the scope of this discussion, but one of the most shocking things that I've learned in the last year is that the greatest indicator of one's health outcomes is not hypertension, it's not diabetes, it's what zip code they live in. So the zip code people live in is the greatest determinant of their health outcomes, which really highlights the disparities throughout the country. And so that is the bottom line here in the discussion. And so we need to figure out as a healthcare system, as a country, how to really fully address that and provide some of these treatments really to people in every zip code and helping every individual get care. So I'll highlight that, even though a full discussion around that is not within the scope of what we've gone through, but to acknowledge it. So let's just go through a couple of the questions that have come up. Now, one of the things, so we had said that at 8 months in that case, patients went on to chemotherapy plus a checkpoint inhibitor. If the individual was less than 6 months, if you're not going to be giving them the chemotherapy, would you still give someone a checkpoint inhibitor? Or if patients have gotten their treatment and they're not eligible to get it with chemotherapy, would you forego checkpoint inhibitor?
Right. So I think if we're in a setting where we can't use the platinum in combination with the immunotherapy and etoposide, then I think we're a true second line. And we saw the results of Checkmate 331. There is really no benefit of using monotherapy, immunotherapy in that setting. So I would go straight to second line. And the options there would be using lurbinectedin, I think. I do worry a little bit about the fact that we don't have any data on CNS activity of lurbinectedin. And so if there is CNS activity, that is certainly something that I'll take into consideration. If they've already had PCI and now they have recurrence with brain mets that are active, that may be somebody that I will use temozolomide in that setting. And certainly clinical trials. I think clinical trials are definitely something that I would strongly consider for this patient. This patient could then look into the possibility of immunotherapy combination strategy in the second line setting on a clinical trial.
I did just have one patient this week that on one cycle of lurbinectedin had a really nice intracranial response. That's the first I've seen. Dr. Weiss, what about you? If you're not giving platinum etoposide, is there a setting where you would use a checkpoint inhibitor alone?
The drugs are active, right? So Nivo failed to beat topotecan in second line. That doesn't change that Nivo alone or Nivo plus IPI is an active regimen. You went over nicely that there are many drugs and regimens that are active in small cell. Each patient situation is different, but I would consider Nivo or Nivo plus IPI as one active treatment that I would consider on that list if the patient hasn't received immunotherapy before and if they're a candidate for it.
Great. Yeah, I'll say I think the medians are a tough endpoint for checkpoint inhibitors. It's a subset of patients that really benefit, but those who benefit, those tails look amazing. So I don't know. I think that's a challenging scenario. I do tend to use a single agent pembro at some point in the hopes that someone experiences that tail. All right, so we've gone through a lot. I want to thank Dr. Leal, thank Dr. Weiss. It is so wonderful to see you both. It's been a long time now with the pandemic and we're doing so much online, but I just so greatly appreciate your talking about these cases with you. So thank you for your participation.
This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/FJX860. This activity is supported by independent educational grants from AstraZeneca, G1 Therapeutics, and Jazz Pharmaceuticals Incorporated.